Hello and welcome everyone to Navigating Migraine with Experts, Not Assumption. Control Migraine, Empower Lives. My name is Simran Chaudhary from Voice of Healthcare, and it is my pleasure to welcome you to this important conversation. Migraine is often dismissed as just headache. For millions of people, it can affect much more than just a few hours of their day. It can interfere with work, education, relationship, emotional well-being, and overall quality of life. And despite this, how common migraine is, many people continue to live with symptoms for years before receiving the right diagnosis or appropriate care. Misconceptions, self medication, delayed consultation, and limited awareness can all contribute to this gap. And that is exactly why today's conversation is important. Through this discussion, we want to move beyond assumption and not towards a better understanding of migraine. How it is recognized, how our understanding of the disease has evolved, what advances are changing, treatment, and importantly, how patients can become more informed and active participant in their own care. This patient awareness initiative is organized by Voice of Healthcare and powered by Amneal Healthcare, with the objective of facilitating informed, evidence based conversation around migraine awareness and management. And we are privileged to have an excellent panel of experts joining us today. Dr. Atul Prasad, Chairman and HOD Neurology at Center for Neurosciences, BLK-Max Superspeciality Hospital, New Delhi. Good evening, sir. Thank you so much for joining.
Thank you. Uh,
Thank you, sir.
okay, so the question was: Is migraine
So
a
I'll
routine? Oh, okay,
just give us a moment. I'll introduce the other speakers and then we'll get back to the flow.
sure.
Thank you, sir. I would like to introduce Dr. Venkatraman Karthikeyan, Senior Consultant Neurologist at Kauvery Hospital, Chennai. Hello, sir. Thank you so much for joining.
Good evening. Thanks.
Thank you, sir. Dr. Aarati Kulkarni, Consultant Neurologist at Aarogyam Superspeciality Clinic, Mumbai. She was supposed to join us, but at last moment, an urgent commitment came, but so she couldn't join. I would like to introduce Dr. Mayank Kumar Shrivastava, Consultant Neurologist at Numeet Superspeciality Hospital, Greater Noida. Good evening, sir, and thank you so much for joining.
Thank you. Thank you for having me.
Thank you, sir. And Dr. Colonel Rajeev Ranjan, Consultant Neurologist at Command Hospital, Chandimandir. Good evening, sir, and thank you so much for joining.
Good evening. Thanks.
Thank you, sir. So, with this, let us begin by a first round of discussion and by understanding the problem itself. I would like to start a discussion with Dr. Atul. So, for many people, migraine is still perceived as something similar to routine headache, something that can simply be managed with a painkiller and carried on. But clinically, we know that migraine can be a much more complex and disabling neurological condition. So, since it is perceived as routine headache, how would you describe it into a true clinical and societal impact today?
Yeah. Okay, so of course, migraine is much more than a routine headache. It's a neurological disease. It's a neurological disorder, and being a disorder, it has consequences. Consequences regarding a personal life, social life, and economic consequences. It can cause recurrent disability, more than just a headache. It can cause a disability which can affect the work production, education, family responsibilities, and quality of life. If a patient goes in for chronic migraine, patient may also have many more loss of productive days in a month. So, its true societal impact extends well beyond just pain. It's not only pain. Migraine is not just pain. It is a neurological disorder, and it should be treated as a neurological disorder and not just any other headache with painkillers.
Thank you, sir. Thank you so much for explaining us that. As we move ahead, we know that there's a lot of misconception associated with migraine. So, Dr. Karthikeyan, even when people experience reoccurring migraine symptoms, there can be a tendency to normalize them, or they simply live with this. So, which misconception about migraine continue to create challenges in timely diagnosis and effective management?
I think most of us would have come across that. I mean, you would also agree that headache has unanimously been considered as a sinus headache across our country. So you ask anyone, they're going to say, I have a sinus pain, I have a sinus. Everybody has a sinus here. But whatever happens as an inflammation causes sinusitis. But even otherwise, migraine is more common than a sinus headache. So what happens when people consider this as a sinus headache? They go just take the steam inhalation. They just say, I have a headache, I will go take steam inhalation. And sometimes for some placebo effect that works, but majority of the times it naturally resolves, and not that the steam has caused the relief in them. Now, okay, even if it's, one may ask, okay, I get spontaneously relieved of it. Why would I? What bothers? Let it be sinus or let it be migraine. But one of the known facts about the migraine headaches is that if you cannot control the number of headaches, that itself is going to be a trigger for the next headache. For example, if you can't abort an headache when it is happening, that itself is going to precipitate a next headache within a few days. So that itself is the reason why an episodic pain becomes a chronic headache over time, and whatever was very much controllable earlier in the period becomes very refractory later in the night. The other point, which is a problem for the problem as a misconception, is that the most bothersome symptoms. So people with migraine do not only complain of headaches. Now let's not assume migraine as only as an headache disease. Now migraine is everything from head to foot. Your lack of attention, your yawning for no reason. Some people just keep yawning for no reason. Your acid reflexes, regurgitation, and nauseous sensation for no reason. Your bodily pain for no reason. They are all known, they don't need to be anything else, but can only be one of the phases of migraine in patients with headache. So a migraine need not always present as headache, it can present with all other symptoms. So patients do go around all the doctors, like they go for gastroenterologist for a regurgitation, they go for yawning, they'll go for a psychiatrist, many things. But a simple understanding that a migraine is the one which is presenting as all these symptoms could take them away from all these polypharmacies, polyconsultation, and give them a better life. So these are the misconceptions that I feel are happening in the society.
Thank you. So, thank you so much for explaining and shedding light on this important aspect of migraine, where we talk about misconception and how people normally deal with it. As we move ahead, my question is to Dr. Mayank. So, early recognition can potentially change the course of care. So, what are the key early indicators that healthcare professionals and patients should recognize to enable early interventions?
Yeah, so as our previous speaker already told, the most important thing is to target here that we focus our attention on the premonitory phase or the pre-symptomatic phase compared to the full-blown symptomatic phase, that is the headache. So most of our patients, they know that headache is happening, it might be migraine, and many times they will come also with the complaint of, sir, I am having migraine. But the thing which get them confused most of the time, and they are not able to recognize and realize it, are the pre-symptomatic symptoms, like we spoke about. The patient can have excessive yawning or the fatigability, low mood, irritability. So the most important thing we have to understand that the migraine headache, along with all these symptoms, they all are related to the neurotransmitters, like the norepinephrine, serotonin, calcitonin-generated peptide. So the disturbances of these neurotransmitters can cause very myriad of the symptoms. And along with these symptoms, sometimes physicians also, they have the tendency to say headache as the cervicogenic headache or the cervical. In spite the patient is presenting with the shoulder stiffness or the neck stiffness, which can be very much symptom for the migraine. But many times we just get it confused to the other headaches or to the other kind of symptoms. Even patients also, they want to correlate with their day-to-day lifestyle activities. Like if they will have excessive fatigability, low mood, they will try to correlate it with the work environment pressure or the personal problems which is going on. Many times, like the belching, excessive belching, bloating. So they will have more tendency toward going for the sir, I'm having severe gastritis, and I have very much problem of the reflexes and all. But these kind of subtle symptoms, if you recognize early, obviously it helps both patients and physicians to intervene early and to give proper treatment to the patients.
I think, sir, you rightly mentioned on the symptoms and the pattern which patients commonly overlook, and they do not associate this with migraine. And that's what important is to, observe carefully what are the signs and symptoms they are facing, and openly speak to their physician, to the doctors. I think that's how they will guide, if they will be able to guide them better. As we move ahead, my next question is Dr. Rajeev. So, we often hear from patients that who say that they have been experiencing symptoms for years, but only seek specialist care very late. So, despite experiencing symptoms for years, many patients today seeking they seek delay in take, having the consultation and the care. So, what factors contribute most to these kind of delays?
Yeah, so many things has been told by the earlier speaker, but I will just to the tell the another aspect of this headache. First of all, as they said, how the migraine, the concept of the migraine. Now I will tell the association of the migraine with the certain circumstances which can lead to, first of all, the types of migraine, as it was said, simple as the basilar migraine or a migraine with the brainstem aura, where the continuous vertigo kind of a thing episodic, and it will keep creating a problem. Patient will roam around here or there, the psychiatrist, the ENT keep taking Vertin and all this thing, and still not getting relieved. The second thing, the that's why they delay for 1.5, nearly 1.5 years. Now come to the second is the common thing. That is the second. For example, the catamenial migraine, very common amongst the women during the menses. They will have this part of even normal migraine aggravate, or they will have the episode only during those menses. Again, they say they normally perceive it. Okay, this is the part of everything. So again, that's why the delay. Now, coming to the next thing, the association of the migraine with the common complication of the neurological problems or neurological diseases. Either you take idiopathic intracranial hypertension, or I'm just starting with the one thing. So what happens? You will find, although migraine is not a trigger for this, but you will find it that more than 60 to 70% of the patient with this disease will have the migraine in the background, and that confusion creates, and by the time they report to the doctor already sometimes late, there is some blurring of the vision, and then straight away you have to look for those suntings and everything. The second part is, normally if all the panelists will be agreed, that is still that if we go to the data, epidemiological data, it is still the female which present in the number, the ratio is almost, for example, in the my clinic, being a command hospital, from the whole the dependency of the west area of the army onto me only, and you can find out nearly 70 to 80% of the headache in the OPD, normally it is by the female. And they have got their different issues, and it will come to know again the type of the headache and all this. These are the few factors. Normally they come late, and straight away they will come, and rather than explaining their symptoms, straight away do the imaging and all this thing. So little awareness is required. These facts are very important as far as those, the picking up the different kind of a migraine and going ahead with the different neurological complication related with the migraine. So that's why we need it, and we need more awareness about it.
Very rightly mentioned, sir. I think most of the times we do not consider these factors which you have mentioned, and I think, according to your experience, according to the patients which come to you, the types of symptoms and the types of conditions they explain to you. I think that's the most common aspect, and that people often overlook about it. As we move ahead, my next question is to Dr. Atul. So now discussing on the advances in migraine science and the precision therapies. So our understanding of migraine has changed considerably, particularly as research has given us insight into the underlying biology and mechanism of the disease. So, how has our understanding of migrant biology disease mechanism advanced over the past decade, and how have these advances translated into the way clinicians approach diagnosis and treatment today?
Yes, you're right. It's a good question. When I was doing my neurology training, a migraine was considered to be a vascular headache. That means there's a trigger and there's vasodilatation in the intracranial arteries, and the patient has a headache. It's a simple understanding. But that has changed over the last decade. It has changed, and we know that now there's a trigeminal vascular system, CGRP signaling, and central brain processing networks which are involved in migraine pathophysiology. We know that there are triggers which activate the trigeminal pathways, and these cause release of a neuropeptide known as CGRP, calcitonin gene-related peptide, which plays a significant role in migraine pain and associated symptoms. And cortical and brainstem networks contribute to the aura, the sensory hypersensitivity, and the chronification. So it's important to understand this because now we have migraine specific medicines. We have medicines which are antibodies to the CGRP pathways, which can abort episodes of headache, or which can prevent headache, which can prevent repeated episodes of this headache. So the more the understanding of the pathophysiology, the more targeted, the more personalized the medicines become. We also are aware now that the hypothalamus, the autonomic pathways, and the genetic mechanisms also come into play in this migraine. And people are working on this hypothalamic peptides, which can also be used. Still not in the market, but perhaps as a future where we can start using them for aborting episodes of migraine. So the more we know about how migraine is caused, the more we can target those neuropeptides which are responsible for causing headaches.
Thank you. So I think you have very well explained us about what are the advances in migraine biology and how these are helping us in terms of the treatment of today's signs and symptoms and the patient studies which we are seeing. Um, my next question is Dr. Karthikeyan. So, one of the significant development in recent years has been the emergence of newer targeted treatment approaches. So, with emergence of CGRP targeted therapies, how do you envision their integration into everyday migraine care?
So, as the previous speaker spoke, we've been battling migraine for ages now. The history unfolded this way that we were battling the migraine with drugs that were actually not designed for migraines. Let's put it this way: if we had to give somebody an abortive drug, like he is experiencing a headache, we were giving a general painkiller, like a painkiller which would work for any muscle disease or a bone disease. That's what we were giving. And if we were to prevent a headache for these patients, we were giving either an antidepressant or an anti-seizure drug. All these were discovered or invented for reasons away from migraine and got repurposed for migraine management. Now, the understanding on the mechanisms of migraine has improved very much, and we have found out the calcitonin gene related peptide is an important protein that triggers these migraine, and also has a protein that is known to be associated with the chronicity of the migraine. Now, identifying these people early and giving them the option of precision medicine. So, what we are going to do, we are not just going to treat them with a general painkiller or a medicine that will only inhibit the pain pathways. We are going to start at the trigger or the initiator molecule by blocking this molecule from attaching itself to the nervous system. We're blocking the molecule by preventing the contact point on the nervous system. We are stopping it at the early initial step itself. So therefore what happens, it is a precise medicine, and there we are also avoiding the side effects which could have happened because of the usage of drugs that were mentioned for some other reason. Most of these medicines that we used in the yesteryears used to have sedation or dry mouth or weight gain as their side effects. Now, with the precision medicine where we are targeting a single molecule, it's almost close to zero. The side effects are zero. Patients do not experience sedation. Patients don't need to avoid driving. Patients don't need to excuse themselves from a meeting like this or in their office work or their household chores, and they can continue to lead their activities of daily living and the occupation by taking these medicines as and when required, on one side for an abortive as an abortive mechanism, or as a preventive drugs as a monthly injections or as an alternate day tablets. It is all possible, and that is the sea shift change in the paradigm of the migraine management in the recent days.
So I think that's how these kind of new targeted therapies and the precision medicines are, able to fit into the broader treatment journey, because there are variety of symptoms and variety of cases where such things are helping patient to lead, despite having migraine, to lead a normal life and to adjust according to the requirements or the busy schedule people were used to avoid earlier. So I think this is a game changer in terms of migraine care. As we move ahead, my question is to Dr. Mayank. So, technology is increasingly becoming part of healthcare, from advanced imaging to digital platforms and monitoring tools as well. So, how are the advancements in imaging, biomarkers, digital health tools, are enhancing the diagnosis and monitoring the migraine care? And also, if you could help us in the kind of things like wearables are helping us to monitor such episodes of migraine as well.
Yeah, so here I would like to keep 2 points. One, obviously, as we advance in the treatment of migraines, so diagnosis-wise, if we talk about the blood biomarkers, the market there are not very conventional blood biomarkers which we can monitor and can see that this is how the migraine is more for the patient or less for the patient. But yes, one thing is obviously very important to understand in migraine, that there is always a sympathetic hyperactivity in a migraine patient compared to the parasympathetic. So their heart rate variability, their heart rate responses, they will be changed. So there are many apps which can track nowadays this heart rate variability in the patients, and which can help or guide the doctors and patients both in seeing that how they are going towards the treatment. Another thing to understand that the stresses like the sleep markers. So if you are not having a proper sleep, obviously the non-fragmented sleep, you will have the headache. You will have the migraine headache, increased propensity toward the headache. So there are many wearable apps which helps you finding out that how your sleep is whether it is fragmented or it is non-fragmented, and how you should modify it. Uh, Many times patient comes to me with the report of magnesium, because nowadays the role of magnesium is also being seen in the migraine. The thing is the blood parameter or blood correlation of the magnesium, that the value of magnesium, we can't correlate how the magnesium level is going inside the brain. So obviously there are the roles, but the blood biomarkers are not there. But yes, the digital apps, they are helping us very much. Along with that, very conventional thing we used to say to the patients, that maintain the headache diary. And because of their day-to-day issues or their busy schedules, they were not able to do so. But nowadays, because of this app system, they can do it very properly, and they can show us in the OPD, which also guides us to help them for the treatment.
Thank you, sir. Thank you so much. And I think that's the way you explain the use of advances in technology. That's how I think they are helping us a lot in terms of having a better treatment and diagnosis as well. As we move ahead, my question is Dr. Rajeev. So, while medications are an important component of migraine management, care does not necessarily end with the pharmacological treatment. So, beyond pharmacological treatment, which evidence based lifestyle and behavioral intervention have demonstrated the meaningful benefit for migraine patients?
Yeah. First of all, what are the stressors? That is known as the stressors. So the stressors has to be, the it should not be the part of your routine life if you are suffering from the chronic migraine. Just example, as it was said earlier, also the sleep. It can be both ways. It's a lack of sleep as well as excessive sleep. Both can trigger this migraine. So you have to avoid that. Means, for example, if taking a nap in the daytime, and rather than taking a 1 hour nap, somebody take a 3 hours and wake up with those, obviously with those headaches. So that you have to take care of that. A simple thing. So sleep is a very important. Then the other, for example, the students normally says, or the new employee says, there that the stress of exam, some career, this thing, and ultimately disturb their sleep, and that is how the comes the second part. The migraineurs, some migraineurs have this tendency, normally say, if there is a direct exposure of a sun or the change of the weather, normally will find it they will have a little problem. So you have to tell if it is possible to avoid it. And normally some things are non-avoidable, as I earlier said, for example, catamenial migraine trigger during those menses. But what you can do during those period of time, that even the abortive treatment can be taken for a day or two. So that is the another way of avoiding it. Third, and one is definitely, one is a migraine. Again, there is a type of migraine. There also little bit of variation of your day to day or your routine life. Again, there are a certain, wine has got a, it has to be, avoided. Not every type of alcohol, but in certain red wines and all things has, it told it should not be go ahead with that. And the foremost thing is, once you are getting a recurrent headache, it's always better to consult a right person, to the right expert. He will take, because it's, again, although it's a more than 99.9% headaches are benign, but still those 0.1% that can be dangerous. You are because see, normally patients comes and straight away tell, I have, doctor, I have got a migraine. So sometimes start saying at him, if so it's better you just come this side of the table and you sit. If you are coming and telling, doctor, I have got a migraine, it's not the way. You tell your problem, that I have got a headache and I will just have got this additional symptoms. So these things should be, if you taken care of, this is the away from the targeted therapy lesson, that will be the integral part of the migraine. There is no doubt about it.
Thank you, sir. Thank you so much for explaining this. As we were discussing this, we have some questions from our live audience. I would like to take one. Currently, we have that my mother often had headache during long distance travel. Now that I have been diagnosed with migraine, I wonder if it's hereditary and could be passed on to my children. Dr. Atul, if you could please help us understand this question from our
Yes,
audience.
yes, of course. I did mention that there are genetic factors which also play a role in migraine, and we inherit migraine from our parents. I mean, there's no doubt about that. The good news is that migraine is not really such a bad disease, such a bad disease, and it can be controlled. It can be controlled if proper treatment is given. Again, do not treat migraine as a headache. Treat migraine as a disease, and we'll talk more about how to control the disease. And if it's controlled, then it's not really a bad thing to have. But the answer to the question is yes. The mother has it, he has it. Chances are his children will also have it.
So, as you have explained us this, I have another question from a different point of view. That how can healthcare providers move from treating migraine episodes to adopting a more proactive and preventive care approach?
So yeah, quite right. It's quite a continuation of the question which was asked. So this is what I always say, that healthcare providers should stop treating headache as an episode based approach and start treating as a longitudinally disease managed model. Treat the disease, do not just treat the headache. This means that we should identify the patient with frequent disabling or progressively worsening headaches, assessing the quality of life and the disability, and introducing preventive therapy as possible. Preventive therapy and not just abortive therapy. So treatment program should consist of trying patient education, trying to identify the triggers and lifestyle management advice, appropriate acute treatment. Of course, the rescue medicine will always have a role to play. Will always have a role to play. We never really promise anyone 100% relief from headache. And what is more important, as the speakers before me have pointed out, that we have evidence-based preventive options, including CGRP targeted therapies. We have a preventive CGRP therapies. We have antibodies which are preventive, or we have CGRP small molecules blockades, which can help both in acute treatment as well as in preventive treatment. We have botulinum toxin A, and we have other conventional therapies. Once we have identified these patients, we have decided to put them on regular follow-up, regular long-term therapy, lifestyle modification, rescue therapy, trying to identify the triggers. The next step is, of course, they need a regular follow-up. And here comes the role of headache diaries, where the patient reports each and every incident of the headache which he or she gets, and why they get it, why they have got it. The question that my long-term travel fatigue triggers migraine in some kind of patient, and then we try to optimize the therapy accordingly. as Dr. Rajeev mentioned, there's something called catamenial migraine, that is the periods, the onset of periods which precipitate hormonal changes, and we try to manage that, and there are strategies for managing catamenial migraine too. The goal of migraine therapy should be that we should offer the patient less disability, reduced reliance on acute treatment, and prevention of chronification. Shifting a migraine from acute episodic migraine to chronic migraine, the single most disservice you can do to your patients. And we should just stop treating them like any other headache, and try to treat it as a disease with all the strategies.
Thank you, so thank you so much for explaining us this in a very simple way, so that our audience can also understand this other perspective. As we move ahead, my question is Dr. Karthikeyan. So patients are ultimately at the center of long-term migraine management. So in what ways can patient education improve treatment outcomes while helping reduce the stigma associated with migraine?
So we've heard from many people now. Now you know that migraine has some amount of genetic background, and there are people who are prone for migraine. So it's not that everybody gets migraine, but there are people that are prone for migraine. Now, so there is a substrate that is get ready to get burnt, and somebody has to light it. That's it. That's the simple thing. And who's that? Who's lighting it? The person who's suffering from it is going to light it. So a migrainer is someone who has either a physical factor or an emotional factor or an environmental factor that triggers this headache. And then sometimes they may not know the internal biological factors like the hormones that can trigger it. So the first and foremost important talk for any patient who walks into the clinic with a migraine headache is not just take the medicine, is to sit with them and identify, okay, maybe this is your trigger factor, maybe this is where you're doing things wrong, maybe what is right for someone may not be right for the other one. Maybe 6 hours of sleep is good for me to function well without a migraine, but that could be 7 hours for the other gentleman or a lady who comes into it. So it's a custom made identification of a trigger that needs to be put in right, and then keeping that as the base substrate, you should also be able to convince them that taking the medicine as an abortive drug, like not the preventive ones, at least the abortive ones at the right time makes a big difference. For some people it may be a matter of prestige or an ego that they don't want to take medicines during the migraine attack. They will say, I will try my level best to not take a medicine. I will try myself to win over this headache of migraine by taking some ginger tea, some applying a balm, whatever methods than the medicine. Let's move away from the concept. Earlier treatment, earlier taking medicines to abort the headache. That is, the timeline is 2 hours. If you are going to come out of the headache within 2 hours of the start of the headache, that goes a long way in reducing the most bothersome symptoms. Let's again not forget that migraine is not just the headache, it is also the impact that it causes on the cognition. For example, if I have a headache today and I get over the headache, the impact is going to go for the next day in my attentive spells in the work. I will be a bit blurred in thinking, and it goes a long way. So the earlier you abort it, the better you are to come back to your reality. So that needs to be very much emphasized. And I carry the rule of 31. The rule of 31 is this, where the first 30 minutes you do whatever in your capacity to reduce your migraine. You can go for a black coffee, you can close the windows, switch off the light, try relaxing your body, and we call it guided visual imagination, where we try to relax the body parts from foot to the brain. Okay, 30th minute, migraine not settled, I would advise people to go for the medication or the pill, whichever works for you as an abortive drug, at the 31st minute, so much so that you get out of the headache within 2 hours. So that is the timeline that we want to take forward for all the patients as a education. And then once you are out of the headache, take the migraine diary that Dr. Atul had mentioned. Write down the headache, when it started, how long did it take for you to take the medicine, and what was the time of relief for the headache, and what was the time of relief for the most bothersome symptom. Like your groggy attention, your nauseous feeling. And then finally, ink down what did you do to trigger this headache. Write the triggers. When you write the triggers only, it will become an information for you. And once the information becomes very clear that okay, this trigger is constant, I need to work on it, and then the trigger gets worked on by your own effort. And this is how the patient education needs to be done in the first visit, without which it will be just pill popping and not the approach to a real cause for migraine.
Thank you, sir. I think you have explained this in a very better way that how can healthcare providers move from just treating migraine episodes to adopting a more proactive and preventive care approach, and the way you guide the patients. I think that is also quite helpful. So while you were helping us understand this important aspect, we got another question from our audience, which says that is there any wearable device that can detect my migraine symptoms and alert me before or during a migraine attack? Dr. Karthikeyan, if you could help us understand this.
Sorry, I missed that part.
So they are saying that is there any wearable device that can detect my migraine symptoms and alert me before or during the migraine attack?
I'm personally not aware of any wearable device like what we use for the cardiac monitoring, for to detect a migraine. Nothing's going to detect a migraine. Nothing better than your own sensor in your body. I think the best detector is your own aura. And some people need not even have aura. They have a premonitory symptom like they will have a dull mood way before the migraine starts. They may have their gut not so happy. They would feel a bit bloated. These are all the symptoms that would be taken as a precursor towards a migraine. Towards the wearable device, I don't think we are there yet to diagnose a migraine before it can happen or alert. And trust your gut is the best thing.
So I think that that's a very valid point because our body starts giving us the symptoms that what is about to happen, and our intuition can catch that quite easily about what how we are feeling. As we move ahead, my question is Dr. Mayank. So a migraine does not exist in isolation. From many patients, there can also be relationship between migraine and mental well-being, like one of the point already mentioned by Dr. Karthikeyan, that you know your gut, your mood, your everything gives you some of the other symptom which you feel like okay now you know this could be a symptom of a migraine. So given the strong relationship between migraine and mental well-being, how critical is multidisciplinary approach that includes psychological factors as well, support as well?
Yeah, so obviously it's very important to understand that there are multiple factors which can trigger migraine pain. But along with that, it is also important to understand those symptoms. Reason being, as we previously spoke about that if you are having premonitory symptoms of bloating, excessive belching, sometimes nausea also, you will straight away go to the gastroenterologist. So that will again provide the economic burden. Plus, you are not visiting the right person who can help you fully. So on the other aspect, if we see many times like the stressors or the anxiety or the personal environment or your working environment can play a big role. And sometimes as a physician, we also don't pay attention to these things very much. Along with that, patients also, they don't understand that these are the things which need to be taken care of. So we are the person who should guide them that, okay, fine, these are the things you should do at home or at your working environment to help yourself so that these migraine symptoms won't come. But because the things are so much, you also have to share those things, or you should also take the help of the psychiatrist or the psychologist. There is always a taboo as soon as we say that you should go to the psychologist or you should go to the psychiatrist, because person understands only one language. As soon as we say that you need psychiatrist, it's always about the illness which is non-curable. But it is very important from our point of view to make them understand that these things has to be taken care of, so that along with the medications you will also get motivated to help yourself, and you will also have a place to speak up whatever problems you are facing in a day-to-day activity. Then I think through this platform, I also want to make clear one point that it is a very important job, the householder members also, because many times I see that we know that females, they have a lot many burden of this migraine headache. And as a couple, when they comes to us and we start telling about the lifestyle modifications, that please do take the breakfast at the proper time, do take the lunch or dinner at the proper time, and limit your screen time, the husband becomes a separate entity. He will start telling more and more that yes, yes, she does that. Yes, I have seen, I've told her many times, she is not understanding all those things. So you should make them realize that they are the team. They are not separate individuals, and the whole psychosocial environment will depend on how the couple works. So in that way, also the multidisciplinary approach helps in migraine a lot.
Thank you, sir. Thank you. You highlighted a very important aspect of this migrant care. So we do have another question from our audience. If you could help us take this. Person says that my migraine episodes have decreased via specialized GFSCFS diet. Gut has to be taken on priority. Decades ago, I was having a migraine once or twice a month. Now it may be once a year or once in 2 years. Trigger was identified and I worked on it. Does diet and all such things does also help in terms of migraine management?
So there is absolutely no doubt in that, that a good and healthy diet, if we follow, obviously it helps in migraine. Diet can be different for different people, but yeah, the very common factor is that if you remain empty stomach, you are going in sunlight, you are not properly hydrated. These are very conventional triggers, which can always have the tendency to cause the migraine pain in a patient. So
Hmm.
diet may differ, different kind of diet. They come. I'm not aware of about any conventional diet which comes in the market that it will remove your
Hmm.
migraine, it will completely set your migraine. But yeah, good and healthy diet is a must for the to win over the migraine.
Thank you, sir. Thank you so much for
But
clearing
uh,
that thing.
one more
So,
point I want to emphasize that sometimes like that green tea, people take it as a very healthy thing, but you should understand they do have certain amount of caffeine. So
hmm.
as we previously heard about, one of our speaker have told that caffeine, it can help, but it can be detrimental for some people also. So few patient came to me like they will take the green tea early morning, empty stomach. Obviously they go and keeping on having headache, but they are not understanding that the green tea is not helping them. So the choice you have to make according to your body intuitions also, you have to understand that everything doesn't work for everyone.
Correct, correct, sir. I think that's a very good message you have given us that everything does not work for everyone. My question is Dr. Rajeev. So, we have spoken about science, treatment, and patient empowerment, but migraine care also exists within a larger healthcare ecosystem. So, what emerging innovation or scientific development are most likely to transform migraine care in the coming years?
Uh, First of all, in coming years, as far as the in again, see, the treatment part, definitely it has become, more and more the target oriented. So as we know, maybe the time will progressive, the more and more regarding the markers through those receptors or those neurotransmitter measurement, things will come. As well as the imaging is concerned, that it is every day it is a progressing. Right now what we find in the imaging, the migraine changes because of those altered intensity, which is again a very non-specific kind of a thing. So that things will be changing, no doubt about it. But as far as the treatment is concerned, where there is the most, it is the cutting edge which is coming in the as a very fast improving this thing. For a few example, as you know, we are talking about the CGRPs, the anticolon antibodies. Actually, this is CGRP right from their, the production and the attachment to the receptor, and the further on this thing. Abortive treatment, for example, those who triptans were there, they have gotten a certain issue. It still it works very well in the abortive cases, but there are the cardiac the problem there. You have to just take care of this, that you should not be using directly. Then coming to the next again, Zapans has come. That is because it has been, recently come to the India and used on the few patients, and it working well again. But the whole idea behind every this thing is, as summing up the things is, right, start from those. First of all, go to the concerned specialist first, even go to the physician, subsequently come to the neurophysician, get identified exactly it's a migraine, what kind of a migraine, and then the choosing the patient. As you said, the female normally it's a very high, and there you will just find it's mostly the CTTH kind of a headache, where normally most of the things doesn't work. Even you have to resort back to those mood stabilizers, valproates, or go to the mirtazapine or something like that. You have to just do it like this. Then come ahead. Then you choose those patients who have the refractory kind of a nature of normally even you are going for a normal prophylaxis, you are using those beta blockers, you are using the flunarizine or topiramate, whatever it is, the patient will tell adding on the medication, and it obviously become like for abortive it becomes overuse medication, and so subsequently now come to the totally target oriented. The issue with the target oriented normally remains is the cost. And India, most of the things, in spite of being a very very good thing, normally cost is always a limiting factor. Either it's a corporate hospitals comes to the, for example, right now, I am from the army, and somehow the army has got no issue of the budgetary this thing is, so that's why we can use it. Even if you talk about this, if using the Erunumab, again it's a costing is around 27-28,000 institutional price I'm talking about. Still we are able to use it because the budgetary constraints is not there. So these are the few factors the overall. So as far as this investigation cutting edge is, so the time will tell how the things will go. Right now there is nothing much about it. Treatment by, yes, that is definitely there are normally high. I choose my patient for this kind of a thing, because to just go in a pyramidal pattern, the broader base will always be the routine prophylaxis, and out of 70, out of 70% will patient will respond to those medication. Then come a little up to the pyramid, and there again you have to use it little, I can say up in the order for oral medication, and then use, then come ahead. Then this come to the first using before the, for example, if I am going for an antibody, I will use the botox botulinum toxin. But again, problem again here with the cost of the botox, but it gives 6 months kind of a window. You don't have to come daily every month for the, and out of those 10 cases if you have taken for the botox, out of those 7 will be again have cured, and 2 3 will be refractory. There you go for those monoclonal antibodies, and still if there are certain patients, for example, that pregnancy related or few patients, there even the rain can be tried. Although the results is not very encouraging, it's okay. Somehow the abortive treatment is fine. So in a crux or in a summary, the management part is much more focused and oriented is still compared to the investigation. Right now we are doing mostly for ruling out the problem related to the migraine, but the management is definitely we are targeting the migraine.
I think so. Thank you so much for answering this, and I think that you have explained us that how such targeted therapies work, and most of the time, the other type of medication or the different treatment also help us to tackle the symptoms and the patients as well. As we are moving ahead to another round of discussion, which is broadly regarding a regional burden and healthcare access and policy, Atul, India is a country with significant geographic, socioeconomic, and healthcare diversity. So, are there any meaningful regional variation in migrant prevalence, triggers, and access to treatment across different parts of India? Even if when we go, to deeper, more of a remote area, or let's say we go to northeast or west of such kind of where the diversity is extreme.
Yes, the short answer is, of course, there's a difference between different parts of India. India is a vast country, and there's there's the differences in different states and different cities. Now, standardized data across all the country is still lacking. We don't have really very good data, and but we know that there's a difference. But before I start talking about the differences, let me just explain that the biology of migraine does not really change. The biology of does not change. What changes is other triggering factors. So, for example, places where there's a very hot climate, extremes of temperature, or whether there's a lot of air pollution. There's a lot of air pollution. There's going to be a higher incidence of migraine in those areas. Now, I work in NCR, and NCR you see a lot of these new boys and girls who work in call centers, who have irregular sleeping habits, who miss their meals very frequently. They're going to have much more frequency of migraine. the stressors are high. The urban population, the stressors are high, and when the stressors are high, stressor is the very important triggering factor, and these patients will be having much more incidence of migraine. Not just to move away, urban areas or big cities, if you're practicing there, the access to doctors and the access to neurologists is very easy. Access to drugs is easy, the access to medicines is easy. So again, you're going to see a population who approach the neurologist earlier, much earlier, before the chronification start. They approach the neurologist much earlier. They are prescribed higher end medicines, and they respond well as compared to rural areas, where most of the time it's still it's just the headaches are just passed off as normal headaches, or just passed off as the sinus headaches or cervical headaches, and not really diagnosed as migraine. Even when they're diagnosed as migraine, they are on the base pyramid which we spoke about, rather than the targeted specific therapies. So there will be a difference between states to states, between urban and rural, between areas which are hot and pollution, full of pollution, and the areas where we are dealing with a population where people are regularly missing sleep, or missing meals, and there's a lot of stress. However, again, I repeat, the biology of migraine does not really change. It's just that the manifestation changes, because mainly because of the triggers and access to treatment, which is different.
Thank you, sir. Thank you so much. So you mentioned about sleep, and a very relevant question from our audience I have. It is based on sleep only. If you could help him understand this, that how about sleep disturbance even after taking sleeping pill and person gets migraine headache due to lack of sleep, maybe due to stress, etc.
Yes, Hito, the question is quite relevant. See, when you have a sleep problem, it's not enough to just take a sleeping pill. You try to find out the cause of the sleeping problem. If it's because of stress, then along with you need more than sleeping pills, which have their own side effects. You need to take medicines to reduce your anxiety, reduce your stress. Decreased sleep has many causes. Many causes. There can be something as simple as shift workers, for example, like some of my patients who work in call centers. So you need to sort out the cause of sleep rather than just taking a sleeping tablet. If sleeping tablet causes good sleep, it causes you still get 7 to 8 hours of sleep, and still your migraines are getting triggered off. Then the trigger there is not lack of sleep; it's the stress or anxiety which we spoke about. So like the question which came before, you sort out all the triggers, the chances are that your headaches will become less. Sort out all the triggers, and if and it's possible that your trigger, the person who asked the question, the trigger may not just be lack of sleep, it may be stress or anxiety, and there the modality of treatment is little bit more. They need more of cognitive behavior therapy. They need little bit more of specific medicines to treat the anxiety and stress, rather than just sleeping pills.
I think so. We need to, the person who has asked the question is should take care of the root cause rather than just one of the symptom of
Exactly.
the root cause.
Exactly, rather than just a symptom. Absolutely right.
Thank you, sir. Thank you so much for highlighting that point. As we move ahead, Dr. Karthikeyan, if you could help us understand that lifestyles and environmental factors are increasingly become a part of conversation around neurological health. So, how do factors such as urbanization, exposures, changing lifestyle, and workplace stress influence migraine burden across region? I think a bit of has been answered by Dr. Atul, but if you could also help us understand the same.
See, by meaning urbanization, what do we say? We are talking that everything is available every time, right? Urbanization is like facilities across time, 24/7. So how is it getting done? It's by a manpower. It's not still an AI delivering us anything, or not a robot, and that manpower needs to work in odd hours. Now, to reflect on it, just look at the ruralization. Nothing's available after 7 o'clock. You get back into your house. You had already done your food by 8 o'clock. Maybe you chit chatted with the nearby neighbors or had some TV serials. And you're 9 o'clock, you're done, right? In urbanization, how many houses do we see the white lights getting off by 9 o'clock? None, virtually none. I'm including us. So that means we are stressing the biological system, which should have otherwise gone into a sleep by 9 p.m. because of the natural secretion of a melatonin, which is the sleep hormone, and we are overburdening it. And we assume that, okay, sleep is my control. I'll sleep by 1 o'clock, wake up by 8 or 9, so that I complete my 7 hours of sleep. But let's not forget, we are, I mean, at least I'm part of this tropical zone in Chennai, where at 5:30 it's already the light that you feel, you sense, your body senses. The birds start chirping, and maybe the school going houses already started to on their mixies, grinders, everything. So internally, you may be thinking that you are sleeping, you are doing well, but your body is not fully relaxing. The body is already awake in a way. So the system is not fully relaxed. The system is in a stress, and with this stress, and you're going to work in a mentally pressureful situation, which I'm sure is not going to be one answer, because every personality changes. Somebody may not take it very seriously. Someone will be very insecure about their job's presence. But at least your physical stress that you're going to put is quite different in the urban population. Now, with this, how can we not expect a migraine? Whereas I think we have to think it in a reverse way. Because like you know the famous campaign by the multinational company that dirt is good, daag achhe hai, right? So if migraine is going to happen to you early with your bad lifestyle, think that it is for good and start working, because if you're not acting for that, you may end up having a coronary artery disease and heart attack. You may be ending up having a stroke. Maybe migraine is also good in a way. The bodies cry to you saying that please take care of me well. I am not very happy with what you're doing. Think about better strategies to work your have something with your work and life balance, and that is it all about. Yes, we are in a situation where the world's showing a lot of crisis. We have to go to work at various odd times to win the bread, but we'll also have to work a way out to balance this life and the stress from the urbanization.
So, as we're discussing this, the diversity and the regional burden and the healthcare accessibility, a last message from you we can get in a regional language, so that would help us connect to the local audience also. A small message in your mother tongue, so that will be really helpful.
So we say this: your listen to your body, listen to its comfort. So உங்க உடம்பு என்ன சொல்லுதோ, உங்க உடம்பு என்ன கேக்குதோ, அதுக்கு கொஞ்சமா உங்க காதுகளை just listen to it. உங்க காதுகளை கொஞ்சம் செவி கொடுங்க. Then your body will thank you. உங்க உடம்பு உங்களை நிச்சயமா வந்து சந்தோஷமா வச்சுக்கும். Thank you.
Thank you, sir. Thank you so much for this message. Dr. Mayank, when we consider the migraine impact, and as we all are here to speak about migraine and to create a greater awareness around this, so migraine can have a quality of hamper on the quality, productivity, mental well-being, and it raises a larger public health question. So, should migraine be receiving greater attention within India's public health priorities and non communicable disease strategies? And if yes, why so?
Yeah, so we have to understand that what kind of population this migraine involves. So we become suddenly very much worried whenever we are seeing that a person who was very much younger, less than 40 years of age, he got heart attack. But here you see, from very long we know, the population which gets their productivity or the lifestyle get hampered by the migraine is the young population. Even we are seeing children like 10, 14 years, 19 years, obviously working age population. So this becomes very important in terms of the loss, which is days which are lost to for the productivity. Because once you have the migraine, obviously you won't be able to attend your working thing, you won't be able to attend the schools. So as a person and as a nation also, we are losing something. So plus a very important point to consider in the migraine, which is it is very much treatable, if I won't say curable, that the attacks frequency can be remained very long. So obviously the productivity can be increased, and all these things can be attained if you have a better and a greater knowledge of your premonitory symptoms and the different kind of very myriad of the symptoms which can happen with the migraine, and which can be present in different kinds of diseases also. So as soon as you understand, yes, I am having the migraine, these are 4 or 5 things which I have to do in my day-to-day lifestyle modifications. You become more aware, and the propensity to convert it into the chronic headache becomes much lesser, and inversely, the productivity increases.
Thank you, sir. Thank you so much for explaining us this. And I think we all would agree to the point that how it is important, that migraine also receives a public health priority and into a non-communicable disease strategy. Um, Dr. Rajeev, if you had the opportunity to translate everything we have discussed today in one meaningful healthcare action, and to advocate for one policy intervention to strengthen migraine awareness, diagnosis, and access to care, what would it be?
First of all, all headaches are not benign, so take it little seriously. So try to go to the healthcare, first of all. Second, migraine is very much treatable. Definitely it's not a curable as said by the previous speaker, but it is very much controllable. Just following those two things will make your life much more productive. It really give, as the speaker said, that it's more or less if you are able to avoid the warning sign, you are much more confident. You are not losing the productive days, whether it's a student or the working class. So to summing up in all three, this better awareness, go to the first, take the proper medication, and lead a very very free life and better life.
Thank you so much, sir. Thank you so much for sharing that closing message with us and amongst our audience. And thank you to all the doctors for sharing your expertise and perspective with us. If there's one thing that comes through from this conversation is that migraine is much more than a headache and understanding. It is the first step towards migraine is better. So, from recognizing the early signs and seeking timely medical advice to understanding what preventive care, treatment options, and the role of lifestyle and patient participation, there is a lot that can change when migraine is approached with right information rather than assumption. So, and everyone watching us here today, if you or someone you know is experiencing recurrent or disruptive symptoms, don't just simply normalize this or continue the self-managing. Managing it. This conversation is with a well-qualified healthcare professionals that can help you understand what you may be experiencing and what appropriate care could look like. So I would like to thank all the speakers present here on behalf of Voice of Healthcare, and thank you so much for joining the Navigating Migraine with the Experts Not Assumption, Control Migraine and Empower Lives, and powered by Amneal Healthcare. Thank you once again and for
Thank you.
sharing your expertise
Thank
and
you.
giving your time.
Thank you.
Thank you.
Thank you.
Thank you,
Thank
everyone.
you.